Welcome to the Deep Dive. We're the show that takes complex subjects, digs into the source material, and really works to bring you the clearest, most useful understanding possible. We're not about surface level stuff here.
Nope, we go deep.
Exactly. Today, we're diving into a truly fascinating and honestly life-changing area of medicine. It's completely transformed how we approach heart disease. Okay, let's unpack this. We're
Yeah.
talking about percutaneous coronary interventions. You probably know it as PCI, or maybe angioplasty and stenting, and the whole broader field of interventional cardiology.
hmm
And our mission today, for you listening, is ambitious. It's to really master the key concepts, the procedures, the why behind it all. We want you walking away understanding this field with the kind of depth, the kind of insight an elite professional would respect.
What's fascinating here is just the sheer speed of evolution in interventional cardiology. It's really incredible. A powerful testament to, human ingenuity, constantly striving for better ways to treat patients. When you step back and think about it, the core idea, going inside a blood vessel to fix a blockage without massive open surgery, that was revolutionary. Just fundamentally game-changing. And how quickly it went from this daring concept to a procedure performed hundreds of thousands of times a year. It's really quite something.
And the history behind it, it's not just a straight line. It's full of these visionary moments, surprising turns. We're going to trace it back, maybe further than you think. We'll definitely talk about the pioneers, people like Charles Dotter back in 1964 laying some crucial groundwork, and Andreas Grünzig, whose work in 77, well, that really opened the floodgates for coronary care.
Two figures, absolutely.
But we're not just listing names. We want to get into the what, sure, but also the fundamental why these techniques work, and the intricate how, the science, the skill, the sheer ingenuity behind saving lives this way. This isn't a quick summary. This is your deep dive aiming for real mastery. So let's start that historical journey. It really kicks off with a truly visionary idea, doesn't it? Back in 1964, Charles Dotter.
That's right. Charles Dotter, a radiologist. And you have to appreciate the context. He wasn't even focused on the heart initially. He was working on peripheral vessels, arteries in the legs, things like that.
Right, not the tiny coronaries.
Exactly. His huge insight was demonstrating that you could actually, non-surgically, open up a narrowed artery using a catheter, basically snaking a tube through the vessel to the blockage.
Which must have sounded like science fiction back then.
Oh, absolutely. Open surgery was the norm. The idea of fixing things from the inside without a massive incision, it was radical. But he proved the concept. He showed it was possible, paving the way for everything that followed.
But applying that to the heart's own arteries, the coronaries, that was the next giant leap, wasn't it? Much smaller, much more critical territory.
Precisely. And that's where Andreas Grünzig made his mark in 1977. He performed the first percutaneous transluminal coronary angioplasty PTCA. The key innovation wasn't just using a balloon. It was his specific design. A small, crucially inelastic balloon catheter. That inelasticity was vital. It meant the balloon expanded to a very precise, predetermined size. It wouldn't just keep stretching and potentially rupture the delicate coronary artery wall.
Got it. Controlled expansion.
Exactly. That clever design allowed him to safely adapt Dotter's peripheral technique to the much trickier, much more vital coronary circulation. It was the breakthrough needed to really start treating coronary artery disease this way.
I just try to imagine the sheer nerve it took for those very first procedures, the pressure, the uncertainty. What were some of the initial hurdles they hit, the things that made them say, okay, we need to refine this?
Oh, absolutely. It was frontier medicine. In those early days, experience was limited, and the equipment, while revolutionary for its time, was still pretty basic compared to now, so the procedures were really restricted.
So what kinds of cases?
Primarily, patients with single-vessel disease, just one blocked artery. And the blockage itself had to be pretty straightforward. A discrete lesion, often in a proximal, easier-to-reach part of the artery.
Why the limitations? Just the tools?
Largely, yes. The early catheters weren't as sophisticated, and importantly, the guide wires weren't steerable like they are today. Navigating complex bends, really tight spots, or multiple blockages, it just wasn't feasible or safe yet.
So what changed? What were the key innovations that let them move beyond those initial simpler cases?
Well, the field evolved incredibly quickly. It was a combination of rapid technological advancement and, just as importantly, growing operator skill and experience. One big step was developing smaller profile balloon catheters.
Smaller balloons so they could get into tighter spots.
Exactly. More tortuous vessels, narrower arteries, without causing as much trauma. But maybe the biggest leap was the guide wire technology. The invention of movable, truly steerable guide wires.
Ah, the rail system you mentioned?
Precisely. Imagine this incredibly fine, flexible wire that the interventional cardiologist can expertly navigate, twisting and turning it through complex coronary anatomy, guiding it past blockages that were previously impossible to reach.
That sounds like incredible dexterity is needed.
It absolutely is. That combination, better guide wires, smaller balloons, plus operators getting really good at using them, allowed the technique to expand dramatically.
Yeah.
Suddenly, they could tackle more complex lesions, multiple blockages, a much wider range of patients.
So the balloon was the first big step, opening the artery. But it sounds like just stretching it open wasn't always the end of the story. The body fights back, right? Here's where it gets really interesting.
You nailed it. That was the big challenge with early balloon angioplasty. Two main problems. Acute closure, where the vessel might suddenly clamp down or tear right after the procedure, and then, even if initially successful, late restenosis, the vessel re-narrowing over weeks or months.
So the fix wasn't always permanent.
Often not. And that's why the introduction of coronary stents around 1994 was such a monumental leap forward. These tiny, expandable wire mesh tubes basically solved those two big problems. Well, the stent acts as a permanent internal scaffold. It physically holds the artery open, preventing that immediate elastic recoil or acute closure caused by dissections, those little tears from the balloon. And by providing a larger initial opening, it also significantly reduced the rate of late restenosis.
By how much?
We're talking about cutting those major complications, acute thrombosis, that immediate clotting, and late restenosis roughly in half. It was a huge improvement in safety, predictability, and long-term results. A true game changer.
Okay, so stents were a massive improvement over balloons alone. But even these bare metal stents, they weren't perfect, were they? Did they introduce new challenges, or was there still room for improvement, leading to the next big thing?
You're thinking exactly right. Bare metal stents were revolutionary, but we still saw significant rates of restenosis inside the stent itself. The body sometimes has this overexuberant healing response. Scar tissue, basically, would grow over the stent struts and re-narrow the vessel.
Ah, the body trying to heal, but doing too good a job?
Precisely. Neo-intimal hyperplasia, it's called. And that's what led to the next brilliant innovation, the drug-eluting stent, or DES, which came onto the scene around 2003.
Drug-eluting, so they release medication.
Exactly. They took the bare metal stent scaffold concept and added a crucial pharmacological component. The stent is coated with a thin polymer layer that contains an anti-proliferative drug.
Anti-proliferative, meaning it stops cells from growing.
Right. It stops that excessive scar tissue growth. The drug slowly elutes or releases from the polymer directly into the vessel wall over a period of, say, 1 to 3 months, sometimes longer. It acts like a localized shield, gently suppressing that overactive healing response.
And the impact, did it cut down restenosis even more?
Dramatically. Drug-eluting stents reduced clinical restenosis by another 50% compared to bare metal stents. For uncomplicated lesions, symptomatic re-narrowing dropped to the 5–10% range. A huge difference for patients.
It's easy to see why they took over.
Absolutely. Today, well over 90% of stents implanted are drug-eluting. They really solidified PCI's place as the primary revascularization strategy for many patients.
So this journey balloon, bare metal stent, drug-eluting stent, it's just incredible. And the scale of it now?
It's massive. PCI is by far the most common revascularization procedure in the U.S. Over 900,000 patients a year. That's more than double the number of coronary artery bypass surgeries.
Wow.
But here's another key point for mastering this topic. Interventional cardiology isn't just about coronary arteries anymore. The field has exploded.
Right, you mentioned that earlier. What else falls under this umbrella now?
We're talking sophisticated procedures for structural heart disease, fixing holes between heart chambers, repairing or replacing heart valves, congenital heart defects in adults. And then there's the whole realm of peripheral vascular disease.
Peripheral meaning?
Blockages in arteries outside the heart, like the carotid arteries going to the brain, the renal arteries supplying the kidneys, the aorta itself, arteries in the legs, even interventions in the venous system. It's a vast landscape now.
Which implies a pretty intense level of training, I imagine.
Extremely rigorous. To become a board-certified interventional cardiologist, you first complete a 3-year general cardiology fellowship. Then you do another dedicated 1 or sometimes 2 years specifically focused on mastering these interventional techniques, coronary, peripheral, structural.
So it's a sub-specialty, almost.
You could say that. It really underscores the depth of knowledge and technical skill required. So for you listening, this deep dive is about getting inside the world of these highly specialized physicians, understanding their tools, their decisions, and the incredible impact they have.
Okay, we've got the history, the evolution of the tools. Now let's really get under the hood. What actually happens during a PCI? Let's walk through it step by step from the moment the patient enters the cath lab. How does it begin? Is it similar to just getting an angiogram?
It starts very similarly, yes.
Right.
Like a diagnostic cardiac catheterization, the first step is getting access to the arterial system. Usually this is done either through the radial artery in the wrist,
Which is becoming more common, right?
increasingly common, yes, or the traditional route, the femoral artery in the groin. Both provide a good pathway to the heart, and the choice often depends on patient anatomy and operator preference.
Now, anytime you're putting wires and catheters inside arteries, clotting is a huge concern. You mentioned the drugs earlier. Can you break down that pharmacological defense strategy again? It sounds critical.
Absolutely critical. It's a multi-pronged attack to prevent thrombotic complications. Patients typically receive aspirin, usually 325 milligrams. Then a potent platelet P2Y12 inhibitor is added.
Like Plavix or newer ones.
Exactly. Galapagos Plavix is one option, often given as a 600 milligram loading dose. Or newer, often more potent agents like Prasugrel, 60 milligram load, or Ticagrelor, 180 milligram load. These drugs work on different pathways to stop platelets from sticking together.
And what if someone can't take pills right before?
Good question. We have an intravenous P2Y12 inhibitor called Cangrelor for patients who haven't received oral agents. It acts very quickly. On top of the antiplatelet drugs, we also need anticoagulation during the procedure itself.
So thinning the blood overall.
Right, preventing the whole clotting cascade. This is usually done with unfractionated heparin or sometimes enoxaparin or bivalirudin.
Are there even more anti-clotting drugs for really high-risk situation?
Yes. In specific cases like a major heart attack, a STEMI, or if we see a very large clot burden in the artery, or during a high-risk acute coronary syndrome, we might add intravenous glycoprotein IBA inhibitors. Drugs like abciximab, tarafiban, or eptifibatide. They provide another powerful layer of antiplatelet effect. Although Cangrelor, that IV P2Y12 inhibitor, is often proving comparable in effectiveness, sometimes with less bleeding risk.
Wow. It really is a carefully orchestrated cocktail, isn't it? Not just one drug, but hitting clotting from multiple angles.
Precisely. It's tailored, dynamic, and absolutely essential for safety.
Okay, so access is gained, the anti-clotting meds are on board. What's next? How do you get from the wrist or groin up to the heart?
Once access is secured, a small tube called an introducing sheath is placed in the artery. This acts as a stable port. Through this sheath, we advance specially shaped guiding catheters.
Shaped to find the coronary arteries.
Exactly. They have preformed curves designed to easily engage or cannulate the opening of the left and right coronary arteries, right where they branch off the aorta. Think of them as guiding tubes pointing the way.
Okay, the guide catheter is in place. Now the wire.
Now comes the workhorse, the guide wire. This is an incredibly thin, flexible, but supportive wire, usually about 0.014 inches in diameter. Using fluoroscopy, that's real-time X-ray, imaging the operator, carefully steers this wire down the coronary artery.
You can actually see this tiny wire on the X-ray.
Oh, yes. You see its tip moving, navigating the twists and turns. The operator manipulates the end of the wire outside the body to steer the tip inside the artery. It's advanced through the stenosis, the blockage, and parked in the healthy vessel beyond it.
And that's the rail.
That's the rail. Once the guide wire is securely positioned across the lesion, everything else follows over it. Balloons, stents, other devices, they all track over that wire.
So what's the typical sequence then? Balloon first, then stent.
Generally, yes. The artery is usually first dilated with an appropriately sized balloon catheter slid over the wire. The balloon is inflated for a short period to open the narrowing. Then the balloon is deflated and removed, leaving the wire in place.
And then the stent goes in.
Most often, yes. A stent, crimped onto another deflated balloon catheter, is advanced over the same wire to the site of the previous dilatation. The balloon is inflated, expanding the stent firmly against the artery wall. The balloon is then deflated and withdrawn, leaving the expanded stent permanently scaffolding the artery open. The guide wire and guiding catheter are then removed.
And how do you close up the access site? The hole in the wrist or groin?
Several ways. For the femoral artery, sometimes simple manual pressure is enough, holding pressure until it clots. More commonly now, specialized femoral arterial closure devices are used. They might deploy a stitch, a collagen plug, or a clip to seal the hole quickly. For the radial artery, manual pressure works, or often an inflatable cuff is applied to the wrist for a period.
And the patient's experience through all this, are they knocked out?
No, typically not fully asleep. It's usually done under local anesthesia at the access site, plus mild conscious sedation. So the patient is awake, maybe a bit drowsy, but comfortable and able to cooperate if needed.
Which contributes to the quick recovery, I imagine.
Absolutely. Because it's minimally invasive, hospitalization is usually very short, often just overnight, sometimes even same-day discharge for stable elective cases.
Yeah.
A world away from open-heart surgery recovery.
Okay, let's get even deeper into the mechanisms. How exactly does balloon angioplasty work at the level of the plaque and the artery wall? What's it physically doing?
Right. When you inflate that balloon inside the narrowed segment, it does a few things. Primarily, it stretches the artery wall outwards. It also compresses and displaces the atherosclerotic plaque material, pushing that fatty buildup sort of outwards and sideways away from the center of the vessel lumen.
Does it break off pieces of plaque? Is that a risk?
That's a common question. Interestingly, significant embolization breaking off pieces that travel downstream is actually quite rare with balloon angioplasty of native coronary arteries. The plaque tends to get remodeled and compressed rather than shattered.
But you mentioned dissections earlier.
Yes, that's the trade-off. Because the plaque often contains hard inelastic components. Stretching it with a balloon can cause these small, localized tears or dissections in the inner lining of the artery, the neointima.
Like tiny cracks.
Exactly. And while often minor, these dissections can sometimes be problematic. They can create a surface, a nidus, that promotes acute thrombus formation, a clot sticking to the tear. And if a dissection flap is large enough, it can actually prolapse into the lumen and obstruct blood flow, sometimes causing acute vessel closure. That was a major fear in the pre-stent era.
Which leads us perfectly to stents. How did they specifically solve that dissection problem? You said they act like a scaffold.
Precisely. Stents were the key to overcoming that acute closure risk. They essentially tack up those dissection flaps. Imagine the stent expanding its wire mesh, pushes those potentially problematic flaps firmly against the vessel wall, holding them out of the way and maintaining a wide-open channel for blood flow.
And how are they made? What gives them that strength yet flexibility?
They're marvels of engineering, typically made from wire meshes of materials like stainless steel, cobalt, chromium alloys, or nitinol. They start compressed, tightly crimped over a deflated balloon catheter.
So they're tiny when they go in.
Very small profile. Once positioned correctly across the lesion, the balloon is inflated. This expands the stent to its predetermined diameter, pressing it against the artery wall. Then the balloon is deflated and removed, leaving the stent permanently implanted.
And they need to be flexible enough to get there, but strong enough to stay open.
That's the design challenge. Flexible enough to navigate curves and bends in diseased arteries, but rigid enough, once deployed, to resist the artery's natural tendency to spring back, that elastic recoil, and strong enough to hold those dissection flaps. It's why they so dramatically improve success and safety, leading to their use in, over 90% of PCIs today.
Okay, and then the final layer of sophistication, the drug-eluting stents, DES. You explained they're released drugs to stop scar tissue. Can you elaborate a bit more on how that works, the coating, the timing?
Sure. So you have the metal stent structure. Attached to that metal is a very thin layer of a polymer. Think of it like a paint primer. Embedded within or coated onto that polymer is the anti-proliferative drug agents like everolimus, sotolimus, sirolimus, paclitaxel were used historically.
And the polymer controls the release.
Exactly. The polymer is designed to slowly release the drug over a specific period, typically 1 to 3 months, maybe a bit longer depending on the specific stent and drug combination. This ensures a sustained local effect right where it's needed in the artery wall, where those cells might otherwise overgrow.
And the impact was that 50% reduction in restenosis compared to bare metal.
Correct. Bringing symptomatic restenosis down to that 5–10% range for many standard lesions, which is why they became the standard of care so quickly.
You mentioned first and second generation DES. What was the difference there?
The main evolution was in the drugs used and sometimes the polymers. First generation DES used sirolimus or paclitaxel. Second generation stents using drugs like everolimus, biolimus, or sotolimus generally proved to be even more effective and, importantly, had lower rates of complications, particularly stent thrombosis, both early and late. So second-gen stents are largely what's used now.
You also mentioned a cautionary tale about biodegradable stents.
Ah, yes. The biodegradable vascular scaffolds, or BVS. The idea was great. A stent that provides support initially, then gradually dissolves over time, leaving just the healed artery. An early everolimus-eluting BVS showed reasonable initial safety. However, longer-term follow-up raised concerns about higher rates of late and very late stent thrombosis compared to durable polymer DS.
So they were withdrawn.
Yes, that specific first-generation BVS was withdrawn from the market. It really underscores the need for rigorous long-term data, even for seemingly beneficial innovations. Research continues in this area, but it was a reminder that progress isn't always linear.
What about drug-coated balloons? Where do they fit in?
Drug-coated balloons, or DCBs, are another tool. They are essentially angioplasty balloons coated with an antiproliferative drug, similar to those on DES, but without the permanent stent scaffold. They deliver a quick dose of the drug during balloon inflation. Their main use currently is in treating in-stent restenosis when a previously stented artery re-narrows. They can reopen the vessel and deliver the drug without adding another layer of metal.
So what does this all mean for the interventional cardiologist's toolkit? It sounds like they have options beyond just balloons and stents for really specific, tough problems.
Absolutely. The standard balloon and stent are the workhorses, but for certain challenging situations, we have specialized devices. Primarily, these fall into two categories: atherectomy devices designed to remove plaque, and thrombectomy devices designed to remove clot.
Atherectomy removing plaque, how does that work? Sounds intense.
It can be. The most common type is rotational atherectomy. It's often described as being like a tiny dentist drill for arteries.
Seriously?
Metaphorically, yes. It has a small, diamond-coated, olive-shaped burr at the tip of a flexible drive shaft. This burr spins at very high speeds, like 150,000 to 200,000 RPM.
Wow.
It's advanced over the guide wire to the calcified lesion. As it spins, it preferentially ablates or sands away the hard calcified plaque, while tending to deflect away from the softer, more elastic, healthy tissue.
What happens to the debris, the sanded off plaque?
That's the clever part. The particles created are incredibly tiny, generally less than 25 micrometers smaller than red blood cells. They're usually small enough to pass harmlessly through the downstream microcirculation without causing blockages.
So when would you use this?
Its main indication is for heavily calcified plaques that are so hard they might resist balloon expansion or prevent a stent from fully expanding. Rotational atherectomy can modify the plaque, making it more amenable to balloon dilatation and stenting. Though with modern stent technology improving, its use is perhaps less frequent than it once was.
Are there other types of atherectomy?
Yes, there's also orbital atherectomy, which uses a different mechanism, an eccentrically rotating diamond-coated crown to sand away calcium, also used for calcified lesions. Directional atherectomy, which physically cuts and removes plaque, isn't really used in coronaries anymore, but sometimes still in peripheral arteries.
Okay, and thrombectomy, that's for removing clots, right? Like in heart attack?
Exactly. When someone presents with an acute STEMI, a major heart attack, the artery is often blocked by a large thrombus, a blood clot. Thrombectomy catheters are specialized aspiration catheters, usually without a balloon, designed to literally suck out the clot.
Why do that before stenting?
The goal is twofold. First, to prevent pieces of that clot from breaking off during the ballooning and stenting, distal embolization, and blocking smaller downstream vessels. Second, to restore some blood flow even before the stent goes in, which might help limit heart muscle damage.
Does it always help?
That's been debated. Large trials have actually shown that routine manual thrombectomy for all STEMI patients doesn't improve overall outcomes and might even carry some risks, like stroke. So the current recommendation is not to use it routinely.
But sometimes.
Yes, in select cases where there's a very large visible thrombus burden, aspiration thrombectomy can still be considered, as it might improve flow in that specific situation. It's become a more selective tool rather than a standard step.
And one more specialized tool you mentioned, protecting downstream vessels, especially in vein grafts.
Yes, distal protection devices.
Mhm.
These are really important when intervening on older saphenous vein bypass grafts.
Why are those grafts different?
Vein grafts tend to degenerate over time, and the plaque within them can be very soft, friable, and prone to breaking off during PCI. This debris embolizing downstream can cause a heart attack in the area the graft supplies. It's a much higher risk than in native coronary arteries.
So how do you protect against that?
Distal protection devices are designed specifically for this. The most common type uses a tiny, collapsible filter, almost like a microscopic windsock basket, mounted on the end of a guide wire.
Like a safety net.
Exactly like a safety net.
Mm.
The wire is advanced across the lesion, and the filter is deployed in the healthy vessel downstream before any intervention on the blockage itself. Then you do the ballooning and stenting. Any debris that breaks off gets caught in the filter basket.
And then you retrieve it.
Yes. At the end of the procedure, the filter basket is collapsed back into a retrieval catheter, and carefully removed from the body, taking the captured debris with it. Studies have shown these devices significantly reduced distal embolization and MIs during vein graft PCI.
Okay, we've got this amazing toolkit: balloons, stents, atherectomy, thrombectomy, filters. The technology is incredible. Now let's talk outcomes. How successful are these procedures typically? And what about the flip side, the risks, the complications? It really feels like a high-stakes tightrope walk sometimes.
It certainly requires precision and careful planning.
Yeah.
In terms of success, what we call angiographic success, meaning achieving less than 20% residual narrowing on the final X-ray images, is very high. We achieve that in 95 to 99% of cases.
That's impressive. Are there situations where success is harder to achieve?
Definitely. Success rates tend to be lower in certain anatomical situations. Very tortuous, winding vessels can be challenging to navigate. Very small diameter vessels are trickier. Heavily calcified vessels can resist delectation.
And those total blockages you mentioned, CTOs.
Right, chronic total occlusions.
Yeah.
Those represent the biggest challenge, with historically the lowest success rates for recanalization for opening them up, especially if they've been blocked for a long time, say more than 3 months.
But you said outcomes are improving there.
Yes, significantly. Success is much better if the CTO is relatively recent, or if it has anatomical features to make it easier to cross with a wire, like a tapered entry point or shorter length. And what's fascinating here is the constant innovation in techniques and equipment, specifically for CTOs.
Like what kind of techniques?
Specialized wires, microcatheters, advanced imaging guidance, and complex strategies like trying to cross the blockage from the normal forward direction, antegrade, and sometimes even coming at it backwards through collateral channels, retrograde. These advances have pushed success rates for CTO PCI up into the 70 to 80% range in experienced centers, a huge improvement for these toughest cases.
That progress is remarkable. But even with high success rates, interventions carry risks. Let's talk about the serious, though hopefully rare, complications. What are the big ones?
You're right, serious complications are rare, but they are critical to understand. For elective non-emergency PCI, the risk of mortality, of death, is very low, typically in the range of 0.1 to 0.3%.
Okay.
The risk of having a large myocardial infarction, a major heart attack related to the procedure, is less than 3%. And the risk of stroke is also very low, around 0.1 to 0.4%.
Are there patients who are at higher risk for these complications?
Yes, absolutely. Risk is higher in older patients, generally defined as over 65. It's higher for procedures done emergently or urgently rather than electively. Patients with pre-existing chronic kidney disease are at higher risk. And understandably, risk is elevated in patients presenting with a STEMI or those already in cardiogenic shock.
Are there ways to predict this risk?
Yes, various clinical scoring systems have been developed and validated. They take into account these patient factors and angiographic features to provide an estimated risk percentage for adverse events, which helps in counseling patients and planning the procedure.
What actually causes a heart attack during a PCI?
Several potential mechanisms. An acute clot, a thrombus could form. A severe dissection, despite stents, could still occur or extend. Embolization, either of thrombus or plaque debris, can block downstream vessels. Or sometimes a side branch vessel originating near the treated lesion can get pinched off or occluded.
Are all procedure-related MIs equally serious?
Not necessarily. Many are actually quite small, detected only by a rise in cardiac enzymes like troponin, measured after the procedure. These small enzyme leaks don't usually have long-term consequences. Right. It's the MIs associated with significant enzyme elevations, often defined as more than 10 times the upper limit of normal, that are linked to less favorable long-term outcomes. And again, the widespread use of stents has really minimized the risk of large occlusive dissections, which used to be a major cause of procedural MI.
You mentioned stent thrombosis earlier, the risk of a clot forming inside the stent. How common is that, and when does it happen?
Stent thrombosis is a serious, though thankfully uncommon complication, occurring overall in about 1 to 3% of patients who receive stents. It can happen at different times. Acute stent thrombosis is within the first 24 hours. Subacute is between 1 day and 30 days. And then there's late, between 1 month and 1 year, and very late stent thrombosis, occurring more than a year after implantation.
What's being done to prevent it?
2 key things. First, meticulous technique during the initial procedure, ensuring the stent is fully expanded and well opposed to the vessel wall. Second, and absolutely crucial, is the use of dual antiplatelet therapy, DAPT. That combination of aspirin plus a P2Y12 inhibitor.
Does the type of stent matter for thrombosis risk?
Yes, it seems to. Late and very late stent thrombosis were observed slightly more frequently with the first-generation drug-eluting stents compared to bare metal stents, which led to recommendations for longer durations of DAP, sometimes a year or even more.
And the newer stents?
The second-generation drug-eluting stents have demonstrated lower rates of late and very late stent thrombosis. This improved safety profile has allowed for consideration of shorter DIPT durations in many patients, sometimes down to 6 months or even less in some situations, depending on a careful assessment of the individual patient's risk of clotting versus their risk of bleeding on the medications.
So stopping DIPT too early is a major danger zone.
A huge danger zone,
Yeah.
especially in that first month after getting a stent. Prematurely stopping DIPT during that critical period increases the risk of stent thrombosis dramatically, potentially 3 to 9-fold.
Wow.
And the consequences are dire. Stent thrombosis leads to death in 10 to 20% of cases and a major heart attack in 30 to 70%.
It's devastating.
Which has implications for other medical procedures, right? Like elective surgery.
Absolutely. That's a critical clinical point. If a patient has a drug-eluting stent and needs non-urgent elective surgery that requires stopping their DAPT, that surgery really should be postponed if possible. Ideally, wait until at least 3 months after the stent, and preferably 6 months or even longer, to allow the stent to fully endothelialize, essentially, get covered by the body's own lining, which significantly reduces the thrombosis risk off the APT.
Okay, beyond the rare but serious risks like death, MI, stroke, and stent thrombosis, what's the most common complication that still occurs after PCI?
By far, the most common complication, or rather limitation, has always been restenosis, the gradual re-narrowing of the treated segment.
The blockage coming back.
Exactly. Now, the rates have plummeted with advancements. With just balloon angioplasty, it was happening in 20 to 50% of patients. Bare metal stents dropped that to 10 to 30%. And with modern drug-eluting stents, we're down to about 5 to 15% clinical restenosis within the first year for many lesions.
How do stents, especially DES, achieve that reduction?
Well, first, just putting in a stent provides a larger initial lumen diameter compared to balloon alone, which gives you more room before re-narrowing becomes significant. Then, the drug-eluting stents add that crucial biological effect. The anti-proliferative drug inhibits the excessive growth of smooth muscle cells and scar tissue, neointimal hyperplasia, over the stent struts, which is the main driver of instant restenosis.
So if restenosis doesn't happen, the fix is generally long-lasting.
That's the key message. If restenosis doesn't occur, particularly within that first year, the long-term outcome for that treated vessel is typically excellent. The durability is very good.
How do patients usually realize restenosis is happening? What are the symptoms?
Yeah. Most commonly, it presents as a recurrence of their original symptoms, usually angina or chest discomfort, typically developing gradually within the first 12 months after the PCI. It feels like the old problem coming back because the blockage is reforming.
Can it present more acutely?
Less often, yes. Maybe about 10% of restenosis cases might present as an end-stemma, a smaller heart attack, and rarely, maybe 2%, as a full STEMI. It's also interesting that very late restenosis, occurring more than a year out, seems more likely to be caused by neotherosclerosis, basically, new plaque buildup forming inside the stent, rather than just the intimal hyperplasia scar tissue we see earlier on.
How is it confirmed, and what's the terminology used?
If restenosis is suspected clinically, confirmation usually requires another coronary angiogram showing significant re-narrowing at the site of the prior PCI. Clinically relevant restenosis leading to repeat intervention is termed target lesion revascularization, PLR, if the same spot is treated again, or target vessel revascularization, TVR, if anywhere the same vessel needs treatment. It's worth noting the angiographic restenosis rate is higher than the clinical rate, as some patients develop mild re-narrowing that doesn't actually cause symptoms.
And if someone does develop symptomatic restenosis, what's the treatment?
Usually the first step is repeat PCI. This typically involves balloon dilatation of the re-narrowed segment, often followed by placement of another drug-eluting stent inside the first one.
Does that fix it for good?
It can, but unfortunately, the risk of a second restenosis after treating the first one is higher. It becomes a more challenging problem.
Are there risk factors that make someone more prone to restenosis?
Yes, several factors are associated with higher risk. Diabetes is a major one, having had a myocardial infarction involving that vessel, certain lesion characteristics like very long lesions or treating small diameter vessels, and also a suboptimal result from the initial PCI can increase the risk.
Are there other options besides just putting in another stent for restenosis?
Yes, for difficult or recurrent restenosis, other treatments might be considered. Coronary brachytherapy, which involves delivering localized radiation via a catheter to inhibit cell growth, was used more in the past. Drug-coated balloons, as we discussed, are often used now, especially for intestine restenosis. And in some refractory cases, coronary artery bypass surgery might be the best option.
All right, we've covered the amazing evolution, the intricate procedures, the successes, and the potential pitfalls. Now we arrive at the crucial decision point. For you listening, aiming for that mastery level, understanding how clinicians decide who gets a PCI and when is fundamental. It's clearly not automatic for every blockage.
Absolutely not. This is where clinical judgment, evidence-based guidelines, and patient-specific factors all come together. Professional societies like the ACC and AHA publish extensive guidelines that synthesize the evidence and provide recommendations for revascularization across different clinical scenarios. Stable angina, unstable angina, and STEMI. They are the comprehensive resource.
Let's focus on chronic stable angina first. Someone has predictable chest pain with exertion, maybe managed with meds. What are the goals of considering revascularization, either PCI or bypass surgery, in that situation?
There are really two main potential goals in stable angina. The first and most common is to improve the patient's symptoms specifically, to reduce or eliminate angina that persists despite trying optimal medical therapy, like beta blockers, nitrates, calcium channel blockers. The second goal is potentially to improve survival, to reduce mortality, but that typically applies only to patients with very severe and extensive coronary artery disease.
So if someone has stable angina, maybe mild symptoms, and they're doing okay on meds, do they need an intervention right away to prevent a heart attack or live longer? What does the evidence show?
This is a really critical point, and the evidence from major clinical trials has been quite, well, paradigm shifting, actually. Landmark trials like Courage, Berry 2D for diabetics, and more recently the large ischemia trial have consistently shown something that might seem counterintuitive. In patients with stable coronary disease who were well controlled on optimal medical therapy or who had only mild to moderate ischemia on stress testing and didn't have high-risk features like severe left main disease or very poor heart function, an initial strategy of routine invasive treatment going straight to PCI or CABG did not actually lead to better outcomes in terms of preventing death or future myocardial infarction, compared to just continuing with optimal medical therapy alone and intervening only if symptoms worsen significantly.
So fixing the blockage didn't necessarily prevent the bad outcomes in those stable patients.
Correct. For many stable patients, it was very effective at relieving angina symptoms if medical therapy wasn't enough, but it didn't reduce the risk of heart attack or death over medical therapy alone in those trials. This has really reinforced the importance of optimizing medical therapy first and supports safely deferring intervention in many stable patients until symptoms become unacceptable or non-invasive testing reveals truly high-risk disease.
Okay, so for those stable patients where intervention is chosen, primarily for symptom relief, how do you decide between PCI and CIBG bypass surgery? That seems like a major fork in the road. Okay, let's unpack this comparison.
It is a major decision, and the comparison between PCI and CIBG, especially for patients with more extensive disease, multivessel or left main disease, has been studied intensely. The Syntax trial is probably the most influential here. It randomized 1,800 patients with 3-vessel or left main disease to either PCI with first-generation drug-eluting stents, paclitaxel-eluting, or CABG.
And what did Suntex find?
At 1 year, there was no difference in the rates of death or MI between the two groups. However, there were important trade-offs. The rate of repeat revascularization needing another procedure was significantly higher in the PCI group, 13.5%, 5.9% for CIBG.
So PCI was less durable in those complex cases?
In that trial, yes. On the other hand, the rate of stroke was significantly higher in the CAG group, 2.2% for PCI-CS.
So higher repeat procedures with PCI, higher stroke risk with CIBG. What about the overall combined outcome?
When they looked at the primary composite endpoint death, MI, stroke, or repeat revascularization, CBG came out significantly better overall, especially in patients who had more complex coronary anatomy based on a scoring system used in the trial. And importantly, the 10-year follow-up results from Syntax confirm these findings, showing a sustained benefit for CBG in these complex patients over the long term.
Does having diabetes change this calculus? Diabetics often have tougher, more diffuse coronary disease.
It does. The FREEDOM trial specifically looked at patients with diabetes and multivessel disease. It randomized 1,900 patients to PCI, mostly with DES or CBG. The results were quite clear. CEBG resulted in significantly lower rates of the primary endpoint, the composite of death, MI, or stroke, compared to PCI in this diabetic population.
So putting it all together, what's the general takeaway from these big comparison trials?
The general conclusion is that for patients with the most severe forms of coronary disease, particularly complex left main disease, extensive three-vessel disease, or multi-vessel disease in the setting of diabetes, CABG generally provides better long-term outcomes, primarily driven by lower rates of repeat revascularization, and in diabetics, lower rates of death, MI, or stroke.
But PCI still has a role in multivessel disease.
Oh, absolutely.
Yeah.
For patients with less complex multivessel disease, including some cases of left main disease with favorable anatomy, PCI can achieve outcomes that are comparable to CABG, especially regarding death and MI, while offering a less invasive approach with faster recovery and lower upfront stroke risk. The decision is highly individualized.
So, beyond just the number of disease vessels or diabetes, what are the specific anatomical and clinical details that push the decision one way or the other for an individual patient?
It boils down to a detailed assessment of both the patient and their specific coronary anatomy. For PCI, we look very closely at the characteristics of the lesions themselves. Where are they located? Proximal is generally easier than distal. How tortuous or angled is the vessel? What's the vessel size? Small vessels are tougher.
And the plaque itself.
Crucial. How severe is the stenosis? Is there heavy calcification? Calcified lesions are harder to dilate and stent effectively. How long is the lesion? Long lesions have higher stenosis rates. Is there thrombus present? That adds complexity and risk.
Are there anatomical patterns where PCI is just generally not considered the best option?
Yes. As we discussed, the most common reason not to proceed with PCI is that the target lesions are deemed untreatable percutaneously. Often this involves a chronic total occlusion, especially one that's long, calcified, has a blunt entry point, or lacks good collateral connections, basically. Unfavorable features for crossing with wire. There's actually a formal ACHA lesion classification system. Type A lesions are the simplest with the highest success. Type C are the most complex, like difficult CTOs, with the lowest success, highest risk. And Type B are intermediate. Overall, maybe 25–30% of patients referred for intervention might not be ideal PCI candidates due to this kind of unfavorable anatomy.
How does that compare to bypass surgery? Are there patients unsuitable for CABG based on anatomy?
It's much less common for anatomy alone to preclude CAB. Only about 5% of patients are considered unsuitable for surgery based purely on their coronary anatomy. When CABG is deemed inoperable, it's usually due to severe patient comorbidities, advanced age, extreme frailty, severe lung disease, very poor heart function, or sometimes technical surgical factors like not having suitable veins or arteries available to use as bypass conduits, or the target vessels on the heart being too small or diseased to attach a graft to poor distal targets.
A key concept seems to be achieving complete revascularization, fixing all the significant blockages. How does that factor into the PCI versus CABG decision?
That's a very important consideration. CEG can typically achieve complete revascularization more often, as surgeons can usually bypass any significantly diseased vessel larger than about 2 millimeters. PCI might be limited by unfavorable anatomy in some vessels, potentially leading to incomplete revascularization if some significant lesions can't be treated percutaneously.
But how do you know if an intermediate-looking blockage is actually significant enough to warrant fixing? Angiograms can be deceiving, right?
Exactly. Visual assessment from the angiogram alone can be misleading for lesions that look maybe 50–70% narrowed. That's where physiological assessment tools become invaluable. Fractional flow reserve, FFR, and instantaneous wave-free ratio, IFR, are techniques used during catheterization to directly measure the pressure drop across a stenosis, quantifying its actual impact on blood flow.
Like measuring how much the blockage is truly limiting flow.
Precisely. FFR involves giving a drug to maximally dilate the vessel and measuring the pressure difference. IFR is a similar measurement done at rest without the need for a vasodilator drug, making it quicker and easier. The FANG trial was pivotal here. It showed that guiding PCI based on FFR, only stenting lesions with an FFR of 0.80 or less, meaning they were hemodynamically significant, resulted in a 30% reduction in adverse events compared to just relying on the angiogram visually.
So physiology trumps anatomy sometimes.
In terms of deciding whether to treat an intermediate lesion, yes. Subsequent trials confirmed IFR is similarly predictive. So the strong recommendation now is to aim for complete revascularization of all functionally significant lesions, using FFR or IFR to guide decisions about intermediate blockages.
This sounds incredibly complex, balancing anatomy, physiology, patient factors, procedural risks. How is the final decision ideally made?
Given all these interacting factors, the optimal approach, especially for patients with complex multivessel disease, involves a collaborative discussion. This is the heart team concept. It brings together the interventional cardiologist, the cardiac surgeon, the patient's referring physician, and importantly, the patient and their family to weigh all the options and arrive at the best individualized strategy. It's truly patient-centered care.
That makes so much sense. Now, shifting gears slightly, what about when patients aren't stable, when they come in with an acute coronary syndrome, an ACS, or even a full-blown STEMI heart attack?
Yeah.
How does PCI fit in there?
The role of PCI in ACS is much more definitive and often urgent. For patients with unstable angina or NSTEMI, numerous trials have shown that an early invasive strategy with PCI is superior to just intensive medical therapy alone in reducing death and recurrent MI, especially for patients identified as being high risk.
How do you define high risk in STEMI unstable angina?
High-risk features include things like ongoing or recurrent chest pain despite medical treatment, elevated cardiac enzymes, troponin indicating heart muscle injury, significant ECG changes like new ST depression or transient ST elevation, signs of hemodynamic instability, low blood pressure, shock, development of heart failure symptoms, or complex arrhythmias. In these high-risk ACS patients, PCI is generally the preferred approach unless the anatomy is clearly better suited for CAG, like severe left main or three-vessel disease, or the specific culprit lesion causing the instability can't be identified or treated percutaneously.
And for STEMI, the big one, where time is muscle.
For STEMI, where a major coronary artery is acutely blocked, rapid reperfusion restoring blood flow is paramount. Both primary PCI, taking the patient directly to the cath lab for immediate intervention, and thrombolysis, giving clot-busting drugs, are effective if performed within the first 12 hours of symptom onset.
Is one better than the other?
Yes. If primary PCI can be performed promptly by an experienced team, typically within 90 minutes of the patient arriving at a capable hospital, or within 120 minutes if transfer is needed, it is generally superior to thrombolysis. It achieves better vessel patency rates and tends to have better clinical outcomes.
So PCI is the gold standard if available quickly.
Correct. PCI is also used after thrombolysis in several scenarios. Sometimes routinely to ensure the vessel is fully open, facilitated PCI, as a rescue procedure if thrombolysis fails to restore flow, or urgently if the patient develops cardiogenic shock.
What about other blockages found during a STEMI PCI? Do you fix everything at once?
That's been a key question. The COMPLETE trial provided important guidance here. It showed that for STEMI patients who also have significant blockages in non-culprit vessels, arteries not responsible for the acute heart attack, a strategy of complete revascularization, treating those other significant lesions either during the initial hospitalization or staged within a few weeks, leads to better outcomes compared to only treating the culprit lesion. So the goal is usually to achieve complete revascularization eventually, not just address the immediate emergency.
We've spent a lot of time on the coronaries, and rightly so, but you've emphasized how much broader interventional cardiology has become. Let's explore that expanding universe now. Where else are these catheter-based techniques making a major impact?
A huge and rapidly growing area is structural heart disease. This involves interventions on the heart structure itself, beyond the coronary arteries. It includes treating adult congenital heart defects and increasingly managing complex valvular heart disease.
Okay, starting with congenital defects in adults, what kinds of things can be fixed without open heart surgery now?
The most common is probably closing atrial septal defects, ASDs, holes between the two upper chambers, the atria. The procedure is done via catheter from the femoral vein in the leg. We guide the catheter up to the right atrium.
Using ultrasound and X-ray guidance?
Exactly. Echocardiography, usually transesophageal echo or intracardiac echo, and fluoroscopy are used together to precisely size the defect and guide placement of a closure device. These devices typically consist of two discs or wire mesh structures connected by a central waist. They're deployed across the hole, essentially sandwiching the atrial septum and sealing the defect.
Like a patch deployed from the inside.
A good way to think of it. The Amplatzer septal occluder is the most widely used device in the U.S. In appropriately selected patients, the success rates are very high, 85–95%, and major complications like the device moving, infection, or eroding through the heart wall are rare.
What about PFOs, patent form and ovale, those small openings that many people have but can sometimes cause strokes?
PFO closure uses a similar technique and similar devices. It's considered for patients who've had a stroke, or TIA, that's thought to be paradoxical, meaning a clot travel from the veins through the PFO and up to the brain, especially if it's recurrent, despite medical therapy.
Has the evidence been clear on PFO closure for stroke prevention?
It's been a bit of an evolution. Initial trials, like Closure I, were actually negative. They didn't show a significant benefit over medical therapy alone for the primary endpoint. This created some controversy. However, longer-term follow-up, particularly from the RESPECT trial, which went out to 10 years, did eventually show a significant reduction in recurrent cryptogenic stroke risk with closure compared to medical therapy in appropriately selected patients. Meta-analyses combining data from several trials now also support a benefit.
So the longer-term data changed the picture.
It did. It highlights how important long-term follow-up is in evaluating these therapies. It's a good example of the scientific process refining our understanding. But it's important to note, PFO closure is not currently recommended for treating migraines, despite some earlier interest in that area.
Are there other congenital issues tackled this way?
Yes, many others. Similar techniques can close a patent ductus arteriosus, PDA, fix certain ventricular septal defects, VSDs, treat coarctation of the aorta, a narrowing, open up narrowed pulmonic valves, pulmonic stenosis, or peripheral pulmonary arteries, and close other abnormal connections. The range is quite broad now.
Okay, moving to valvular heart disease. You said this is the most rapidly growing area. Let's start with the older technique, balloon valvuloplasty. Still used.
Yes, but its role has become more defined, especially with the advent of valve replacement techniques. For mitral stenosis, specifically rheumatic mitral stenosis where the valve leaflets are fused but still pliable, balloon mitral valvuloplasty is still the preferred treatment if the anatomy is favorable.
Favorable meaning not too calcified.
Right. Pliable leaflets, fused commissures, minimal calcification, and not too much damage to the structures underneath the valve. In these patients, using a special balloon, like the Inui balloon, advanced across the atrial septum, we can carefully inflate it within the valve to split the fused leaflets. It often doubles the valve area, and the results can be excellent, comparable to surgical repair, commissurotomy, with high success rates around 95% and low complication rates.
What about for aortic stenosis? Using a balloon to open the main outflow valve.
Balloon aortic valvuloplasty, BAV, is different. It's performed retrograde from the femoral artery across the aortic valve. While it can temporarily improve the valve opening, the results are much less durable than for the mitral valve. Restenosis happens quickly, often within 6-12 months in 25-50% of patients.
So it's not a long-term fix.
Generally not. Its main role now is limited. It might be used as a palliative measure in patients who are too sick for any definitive valve replacement, or sometimes as a temporary bridge to stabilize a very sick patient before they can undergo surgery, or, more commonly now, transcatheter aortic valve replacement, TAVR. But BAV itself carries risks and doesn't offer a good long-term solution for most.
What about leaky valves? Mitral regurgitation specifically? Can that be addressed with catheters?
Yes, this is another exciting area. For severe mitral regurgitation, the metric clip device is available. Using that transeptal approach again to get into the left atrium, a steerable catheter delivers a small metallic clip.
A clip? What does it do?
It's positioned to grasp the middle portions of the anterior and posterior mitral valve leaflets and clip them together. This effectively creates a double orifice opening, reducing the amount of backward leakage, similar in concept to a surgical technique called the Alfieri stitch.
How effective is it?
The initial Everest 2 trial showed it was safer than surgery, but perhaps less effective at completely eliminating regurgitation. However, its role has really been defined by subsequent studies, especially for patients considered too high risk for open-heart surgery. And critically, the Carapati trial showed a major mortality benefit in a specific group of heart failure patients with functional mitral regurgitation, where the leak is due to changes in the heart size and shape, not primary valve damage. In those carefully selected patients, MitraClips significantly reduced death and hospitalizations.
That sounds like a big deal for those heart failure patients.
It really was. It proved that addressing the functional MR in the right patients could change their trajectory.
Okay, now the one we hear about most. TAVR, transcatheter aortic valve replacement. Stenosis.
TAVR has been nothing short of revolutionary. It's now an established,
How does it work? You're putting a whole new valve in via catheter.
Essentially, yes. A new biological valve, usually bovine or porcine pericardium sewn onto a metal frame, is crimped down onto a delivery catheter. Several types exist. Some are mounted on a balloon that expands the valve into place, like the Edwards Sapien valve. Others are self-extending frames that open up once released, like the Medtronic CoreValve or Valving or Boston Scientific Lotus.
And how durable are these valves?
Durability data so far has been excellent out to 5-10 years, appearing comparable to surgical bioprosthetic valves in many studies. We're still accumulating the very long-term data beyond a decade, but the results to date are very encouraging.
How is it delivered? Usually the leg artery.
Yes, the most common access route is retrograde via the femoral artery. The catheters are relatively large, so good peripheral arteries are needed. If femoral access isn't possible due to vessel size or disease, alternative routes can be used the subclavian artery under the collarbone, directly through the aorta via a small chest incision, transaortic, or through the apex of the left ventricle, transapical, though these are less common now.
Walk us through the deployment.
Often, a balloon valvuloplasty, BAV, is done first to prepare the narrowed native valve. Then, the new transcatheter valve on its delivery system is carefully positioned across the native aortic valve under fluoroscopic and sometimes echo guidance. Once position is confirmed, the valve is deployed either by inflating the balloon or by unsheathing the self-expanding frame. Post-deployment balloon inflation might be done to ensure a good seal.
Success rates. Risks.
Procedural success is very high, typically over 90%. The main risks include stroke, vascular complications of the access site, bleeding, kidney injury, and the need for a permanent pacemaker, which is more common with self-expanding valves. 30-day mortality varies widely depending on the patient's baseline risk, ranging from maybe 1–3% in low-risk patients up to 5–15% or more in the initial trials of extreme-risk patients.
And the trials really showed its value, right? Especially for those who couldn't have surgery.
Absolutely. The PARTNER trial was pivotal. In patients deemed inoperable, TAVR resulted in a massive 55% reduction in one-year mortality compared to standard medical therapy. In high-risk patients, TAVR was shown to be non-inferior and in some studies superior to surgical aortic valve replacement, SAVR. Subsequent trials in intermediate and low-risk patients have also shown TAVR to be non-inferior or even superior for certain endpoints. This led to its approval across all surgical risk categories, fundamentally changing aortic stenosis treatment.
What if a patient already has a surgical valve, but it's wearing out years later? Another big surgery.
Not necessarily anymore. For patients with degenerated surgical bioprosthetic valves, either aortic or mitral, who are high risk for a redo operation, we can perform a valve-in-valve procedure. It's quite elegant. A new transcatheter valve is deployed directly inside the failing surgical valve. It's proven to be a very effective and much less invasive option for these patients.
It seems like almost every valve is potentially treatable now.
We're getting there. Percutaneous pulmonic valve replacement is done, often for congenital heart disease patients with failing conduits, using devices like the Melody valve. And interventions for the tricuspid valve are also rapidly developing and increasingly performed. It's a dynamic frontier.
Shifting focus again, away from the heart itself. What about the other major blood vessels? Peripheral artery disease? Carotids.
This is another major pillar of interventional cardiology now, often overlapping with vascular surgery and interventional radiology. Percutaneous techniques, angioplasty, and stenting are highly effective alternatives to surgery for symptomatic blockages in many peripheral territories.
Like the carotid arteries, isn't surgery the standard there?
Carotid endarterectomy, surgical plaque removal, has been the long-standing standard. However, carotid artery stenting, CAS, has emerged as a less invasive option. Randomized trials initially supported CAS primarily for patients considered high risk for complications from endarterectomy. More recent trials comparing CAS and endarterectomy in average-risk patients have shown broadly similar outcomes for the major endpoints of stroke, MI, and death. Although there might be subtle differences in periprocedural risks, slightly higher minor stroke risk with CAS, slightly higher MI risk with surgery. The choice really depends on individual patient factors, anatomical suitability, and local expertise.
What about arteries in the legs for claudication or critical limb ischemia?
Huge area for intervention. PCI techniques are constantly improving for peripheral artery disease, PAD, tackling longer and more complex blockages, even total occlusions that previously required bypass surgery. We're also seeing the benefits of drug-coated balloons and drug-eluting stents in peripheral arteries, significantly reducing restenosis rates compared to plain balloon angioplasty, just like in the coronaries.
Does training cover all this?
Increasingly, yes. Many interventional cardiology fellowships now include extensive training in peripheral vascular interventions, sometimes requiring an additional dedicated year to gain full proficiency across coronary, structural, and peripheral domains.
Let's talk about support for a failing heart or lungs. If someone is in shock or unstable, what can be done percutaneously to help?
This is critical care cardiology meeting interventional techniques. We have several percutaneous mechanical circulatory support, MCS devices. They can be used to manage cardiogenic shock, stabilize patients during high-risk PCI procedures, or bridge patients to recovery, or more definitive therapies like transplant or durable surgical pumps.
What's the most common one?
The oldest and still widely used device is the intra-aortic balloon pump, IABP, developed back in the 60s. A balloon catheter is placed via the femoral artery into the descending aorta. It inflates during diastole, when the heart rests, and deflates just before systole, when the heart pumps.
What does that achieve?
This counterpulsation does two main things. Inflation boosts pressure in the aorta during diastole, improving blood flow to the coronary arteries. Deflation just before systole reduces the pressure the heart has to pump against, afterload, making the heart's work easier. It provides modest hemodynamic support.
Are there limitations or risks?
Yes. It's contraindicated in patients with significant aortic regurgitation, leakiness, or aortic dissection. Main complications are vascular injury at the access site or clot formation, so anticoagulation is needed.
What about more powerful support options?
We now have several percutaneous ventricular assist devices, PVADs. The Impella family of devices are widely used. These are tiny microaxial pumps mounted on a catheter, inserted via the femoral artery, and positioned across the aortic valve, directly pumping blood from the left ventricle into the aorta. They can provide much higher levels of support from 2.5 up to 5 liters per minute or more, depending on the device size. Smaller ones are fully percutaneous. Larger ones might need surgical cut-down for access.
Any others?
There's the tandem heart device. This uses a cannula placed transeptally from the femoral vein into the left atrium to draw blood out, and an external centrifugal pump returns it to the femoral artery, providing up to 5 limit of support. It's quite effective but more complex to insert. And for the most severe cases, providing both cardiac and respiratory support, there's peripheral veno-arterial extracorporeal membrane oxygenation, VA ECMO. Large cannulas are placed in the femoral vein and artery, connected to an external circuit that oxygenates the blood and pumps it back into the body, essentially bypassing both the heart and lungs. It can be initiated emergently in the cath lab or ICU.
Amazing technology. Finally, two other areas, pulmonary embolism and resistant hypertension. Any interventional approaches there?
Yes, both are areas of active investigation and development. For pulmonary embolism, PE, particularly massive PE, causing hemodynamic instability, or some submassive PEs with signs of right heart strain, catheter-directed therapies are emerging as alternatives or adjuncts to systemic clot-busting drugs or surgery.
What do these catheter therapies involve?
Several techniques exist. Direct aspiration of the clot using large-bore catheters. Infusing low-dose clot-busting medication directly into the clot, sometimes combined with aspiration or fragmentation. Ultrasound-assisted thrombolysis uses catheters that emit ultrasound energy to help break up the clot and enhance drug penetration. Rheolytic thrombectomy uses high-velocity saline jets. Success rates are improving, but the precise role and optimal technique are still being defined in ongoing trials.
And for that really stubborn high blood pressure, refractory hypertension, renal denervation.
Renal denervation generated a lot of excitement initially. The idea is based on the role of sympathetic nerves running along the renal arteries in regulating blood pressure. The procedure involves using a catheter, usually with radiofrequency energy, to ablate or denervate these nerves.
Did it work?
Early non-randomized studies showed very promising blood pressure reductions. However, the large, rigorously designed, sham-controlled Simplicity HTN-3 trial failed to meet its primary efficacy endpoint. It did not show a significant difference in blood pressure reduction between renal denervation and a sham procedure in patients on standardized medical therapy.
So it didn't pan out.
That initial major trial was disappointing and tempered enthusiasm. However, research hasn't stopped. There's ongoing work refining the technique, ensuring more complete denervation, and investigating different patient populations. Some smaller, more recent trials using newer technology or different protocols have suggested modest efficacy, but its definitive role remains uncertain, pending results from further large-scale evaluations. It's a real-world example of how science progresses, promising ideas need rigorous testing, and sometimes the results lead us back to the drawing board. #outro.
Wow. What an incredible sweep through this field. From Charles' daughter just thinking about putting a catheter in a leg artery to replacing heart valves and supporting failing circulation percutaneously, the evolution is just staggering. So stepping back, what does this all mean for someone trying to truly grasp modern cardiovascular medicine?
It means understanding that interventional cardiology is a profoundly dynamic and expanding field. In the coronary space, techniques continue to be refined. Second-generation drug-eluting stents have markedly improved PCI outcomes, making it safer and more durable, especially for complex cases. PCI is the undisputed standard for acute coronary syndromes, saving countless lives, and it's a highly effective tool for relieving symptoms in stable disease when medical therapy isn't enough.
And the decision-making is key.
Absolutely. The heart team approach is crucial for complex cases, ensuring that the decision between PCI and CIBG is truly individualized, weighing all the risks and benefits. And beyond coronaries, the growth is explosive. Peripheral interventions are routine. Structural heart disease is arguably the most exciting frontier right now, with TAVR fundamentally changing aortic stenosis care, MitraClip impacting mitral regurgitation, and new therapies emerging constantly for other valves and congenital defects. We're only going to see more growth in these minimally invasive approaches.
It really is mind-bending. The pace of change we've discussed today, it makes you wonder. Given that incredible journey, from a simple balloon to valve-in-valve TAVR, what part of interventional cardiology do you think might see the most disruptive, maybe even unexpected leap forward in the next 10 years? Something for all of us to ponder as this field continues to reshape medicine. Thank you for joining us on this deep dive. We hope you feel equipped with a much deeper understanding of PCI and the vast world of interventional cardiology, ready to engage with this topic at a truly informed level. Keep learning, keep questioning. We'll see you next time.